Thanks, Fola. Hi, everyone. Welcome, welcome. We'll give a couple of minutes for folks to join us, and then we'll get started. I was looking through where people are joining us from today, and I saw people from the States, from the UK, from New Zealand, all across Canada. I think there's, yeah, it's great. All right, let's get things started. I think we'll, just get moving and let other people join us as we continue along. So hello and welcome, everyone. My name is Rebecca Penn. I'm the project manager for the National Safer Supply Community of Practice. And I'm delighted to welcome you all here today for the launch of the London InterCommunity Health Centre Safer Opioid Supply Program 2023 Evaluation Report. So we're coming together today from across Turtle Island as people of treaty lands and ceded and unceded territories. I myself am located in Mi'kmaq, the territories of the Mi'kmaq people. Most of us here today work in sectors whose goals are to address social and structural harms and to make the world a more equitable and just place for all. We recognize that the production of harms arise from our history of colonialism and its ongoing practices, institutions, and ways of thinking. We know that Indigenous people, as well as members of the African, Caribbean, and Black communities, are disproportionately harmed and criminalized by drug policies and other social institutions that are rooted in racism and colonialism. Colonialism is with us today, and we must commit to working in ways that transform racist and colonial institutions and practices to repair harms, prevent future harms, and work towards a more just, inclusive, and equitable future. I invite you to put your name in the chat. I see some folks are already doing that and saying where you're joining us from. It's great for us to see who's here. For those of you who aren't familiar with the National Safer Supply Community of Practice, let me give you a really quick rundown. The Community of Practice is funded by Health Canada's Substance Use and Addictions Program, and we're a collaboration between London InterCommunity Health Centre, the Canadian Association of People Who Use Drugs, the Alliance for Healthier Communities, and Ontario Aboriginal HIV/AIDS Strategy. Our goal is to help support the scale-up of prescribed safer supply through capacity building and knowledge exchange. Our focus is predominantly on the medical model, and a model that is delivered from a harm reduction and public health approach. We also support advocacy and research and development around non-medical models and decriminalization. I'd love to encourage you to take a look at our website. Our website has so many resources there for you. Lots of information about what is safer supply, some great discussion tools, an evidence brief, and more information about the activities that the community of practice engages in and the resources that we provide, including consultation services for clinicians. We also have archived webinar recordings there, and you can find out about future events that we have by going to our website. So I will say that one of the things that we have been really busy with lately has been have been webinars that focus on research and evidence. Just last week we had one by the Safer Opioid, the Ottawa Safer Supply, Safer Supply Ottawa program evaluation. And they were sharing findings from their latest evaluation that focused on safer stimulant supply. And that recording is on our webinar, or on our website. But also on our website, you'll find a lot of other program evaluations. The research and evaluation reports that are coming out these days, we're having trouble keeping up with it all. So there's over 20 peer-reviewed publications that are out there now, and we're expecting many more publications and evaluation reports to come out over the next few months. And today we have with us Dr. Gillian Kolla and Dr. Andrea Sereda, sharing their findings from the second evaluation of the LIHC SOS program. And you'll find the report alongside the video recording of the webinar and other resources on our website as soon as we're able to get them up there, probably later this afternoon. So just before I turn it over to Gillian and Andrea, let me just do some housekeeping. We are recording this event. Like I say, we'll have it up on the website as soon as we're able to. If you are having technical difficulties, your best bet is to log off and then log back in. You can enable closed captioning there's a button on the bottom of your screen. And that's available in English only. If you did want a French translation of the transcript of the video, we can arrange that upon request. We do welcome you to use the chat box. Our team will be moderating the chat box there and plopping in some resources, links to different papers, articles, reports, and more. So keep an eye on the chat for that. If you have questions for Andrea or Gillian, please use the question and answer box. And if you put it in the chat, we'll lose it. So please put it in the question and answer box, and we'll try to address those questions along the way. We're also going to launch a quick poll between just after the presentation that helps us get some information for our funders, but more importantly for us as a team to understand who we're reaching and how the webinars are being received. We also have a certificate of attendance that we'll make available for folks about halfway through the webinar. We'll drop a link in the chat box. You follow that link and you'll get a certificate in your inbox. And again, I invite you to visit our website for more information about the work of the community or practice. And with that, I'm so happy to pass it over to Andrea and Gillian. Let you take it away from here. Thank you.
Thanks so much for that, Rebecca, and thanks to the community of practice for welcoming us here today. We have a pretty large audience, which is awesome to see everybody taking the time to come here and hear about the work we're going to present to you. I'm Dr. Andrea Sereda, and I'm the clinical lead of the Safer Opioid Supply program here at London InterCommunity Health Centre. We're really excited to share this evaluation. It really documents the impact Safer Supply has continued to have on the lives of people who use drugs in London. Next slide. And we would like to acknowledge all of the people who have contributed to expanding this evidence base for safer supply. In particular, we acknowledge the brave work of people who use drugs as they guide us in the development of safe supply. And we thank all drug users who have acted as subject matter experts, who have participated in our advisory committees, and who have given us informal feedback to make prescribed safer supply what it is today. Next slide. I think it's pretty well known. We've been operating Safe Supply here in London at the InterCommunity Health Centre since 2016. And there was a real sea change in London between 2014 and 2016 when fentanyl went from being this contaminant in the unregulated street supply to dominating the unregulated supply. And prescribed safer supply here at the health centre, it was a response to that early devastation that was happening in London as fentanyl became the dominant product on the street. And I have been completely honest about this. In 2016, I felt completely overwhelmed with the number of people we were losing to fentanyl. More traditional addiction medicine interventions like methadone alone, they were not cutting it to meet the needs of folks at that time period. And people who were going away to things like residential abstinence-based treatment or jail or hospital were returning to our community with no opioid tolerance, and many of them died. You know, I've been a physician for 16 years now, and I have been working with people who use drugs since 2010, well before fentanyl hit the streets in London. I also worked for years as an emergency room doc. I'm used to seeing death. But what was happening on the streets of London from 2016 onwards, the number of people who were suffering and dying was shocking. Next slide. For all the people who use drugs in the audience today, I was seeing my patients die. But for people who use drugs, these are your community members, your friends, and your family. Next slide. And I would like to take a moment to acknowledge everyone we have lost to this toxic drug crisis. In recognition of the almost 40,000 dead across Canada, I would encourage you, if you're comfortable, to share a name or an initial of someone you have lost. Slide. So it's people who use drugs, and probably some of the names that are appearing in the chat right now, who push Safer Supply forward. We hear all the time about meeting people where they're at in harm reduction. And as you contemplate what we're going to discuss in this presentation, I want you to remember that meeting people where they're at doesn't just mean putting on a backpack and going to an encampment. It really means centering the voices of the people you're serving, treating people as experts in their own lives, meeting them in their own cultural and social contexts, and treating them as colleagues and equals. It means recognizing that poverty, colonialism, classism, capitalism, structural violence, they are all the foundation of the fentanyl crisis we find ourselves in today. And Safe Supply prescribers, we stand on the shoulders of brave drug user activists who have pioneered harm reduction across this country. And again, another reflection point. I would like to pause and think about the fact that everything we currently take for granted in harm reduction, it was once illegal. And drug users have borne the burden not just of surviving decades of stigma and marginalization, but they've had to take on the enormous and brave job of creating and implementing life-saving solutions. Needle exchanges were illegal in the 1980s when people were trying to save their friends from HIV. Safe injection sites are becoming more common in Canada, but before Insight, drug users risked their own legal freedoms by operating underground safe injection sites to save the lives of their peers. And naloxone's in every street corner in Canada these days, but before that, harm reduction activists had to beg and borrow naloxone for a decade before the government provided it. And Safe Supply has been on the lips of almost all drug user activists for years before our team discovered what it was. And so just like every other harm reduction intervention that people who use drugs have come to us with, they also knew what the antidote to fentanyl might be before doctors like myself had a clue. And acknowledging as well that Safe Supply is about so much more than drugs. It's about building relationships with people who have been pushed to the margins, and it's about ensuring medical professionals provide comprehensive care to people who use drugs. Next slide. CAPUD is the Canadian Association of People Who Use Drugs, and they have put out a policy document in 2019 that defines safer supply. CAPUD says safer supply refers to the legal and regulated supply of drugs with mind and body altering properties that traditionally have been accessible only through the illicit market. Next slide. And prescribed safer supply builds upon what we learned from CAPUD, and prescribed safer supply now exists within this growing and robust evidence base, and Dr. Kolla will be reviewing our most recent contributions to this evidence. And I'm really happy that we're now in the position to share more evidence about the impact safer supply is having on communities, people who use drugs. Next slide. Before we do that, I think it's important that we acknowledge that in the past 6 months, we have seen Safe Supply attacked by those who wish to eliminate harm reduction generally across Canada. Research like the research we're going to show with you today is being attacked for incorporating the voices of people who use drugs. Critics in the media, some politicians are intent on devaluing and dismissing what people who use drugs tell us about their experiences on Safe Supply. And this really, it acts to dehumanize people who use drugs, because the narratives being created is that people who use drugs will lie about their experiences on the program. And the narrative that drug users lie, compulsively lie, it paves the way for things like forced treatment, because we no longer have to listen to the voices of people with lived experience. Next slide. We have seen safe supply be turned into a political wedge issue and used to inflame stigma and violence against people who use drugs. Next slide. And the attempted rebranding of safe supply to public supply of addictive drugs, or PSAD. This terminology functions to reassert the pathologization of substance use and reaffirm the centrality of carceral models that are focused on surveillance and strict control of drug users. Next slide. We are seeing some provinces move towards a lock-em-up approach to people who use drugs. Next slide. We see statements about do no harm, but do no harm, it neglects the harms of doing nothing. There is real harm in doing nothing or continuing to do the same old thing that is not meeting people's needs anymore, while tens of thousands of people die. Next slide. We are hearing so many negative anecdotes about safe supply in the media, but it's not what people who use drugs tell us. Let us, recenter the voices of people who are in the middle of this toxic drug crisis, recenter the voices of people who use drugs. Let us recenter the fact that this is an emergency and that every harm reduction program, not just safe supply, that is attacked or closed means that more people will die. I want us to recenter working together to save lives, because we need all hands on deck right now. We need safe supply. We need an expansion in access to methadone and buprenorphine. We need residential treatment beds for people who've been on waiting lists for months and months. We need the continuation of services like safe injection spaces. We need this wide spectrum of options. Harm reduction and treatment should not be enemies. They should be collaborative partners. And so let none of us here give into the temptation of partisanship or siloing of approaches, or this binary mindset that says harm reduction and treatment cannot coexist. I invite everyone here to listen to Dr. Kolla as she reviews the most recent evidence coming out of the Safe Supply program here in London, with the spirit of an open mind and the goal of saving lives. So with that, I am going to turn it over to my esteemed colleague, Dr. Kolla.
Thank you so much, Dr. Sereda. So just to start off today, I'm going to focus us in on the evaluation. This is the second evaluation report that we have worked on in collaboration with the London InterCommunity Health Centre. But before I start, I just want to pick up on something that Andrea has said. Compared to when we did the first release of the evaluation report that came out in 2021, there's been a really rapid development of the evidence base around safer supply in Canada. And I would invite everybody to consult the rapid review of the evidence that was completed by the Ontario Drug Policy Research Network this summer, which really does a really good job of highlighting some of the high-level themes that are coming out of the 15 peer-reviewed publications that have been published in medical and scientific journals, as well as the 5 program evaluations that were included. And since this review was completed in July, there's actually been 5 new publications on safer supply. It's a really exciting moment because we're seeing the development of an evidence base that is being built by multiple teams in multiple provinces, multiple groups that are really doing strong research in different areas. It's also using multiple methodologies. And at this point, I think that's one of the major strengths of the evidence base. We're seeing qualitative research coming out. We're seeing quantitative research or survey-based research, as well as research using health administrative database, so people's interactions with the health system. And all of this research is starting to coalesce around some key themes right now, which I think is important to review very quickly before we move into the new evaluation results. Significantly, the research to date has been finding very low rates of drug-related overdose, opioid-related toxicities, as well as significant decreases in emergency department visits, hospitalizations for serious infections, as well as significant reductions in healthcare costs. People who use drugs and who are part of these programs are telling us that they're seeing very strong improvements in their mental and physical health, as well as better access to healthcare services. Programs are seeing very strong retention, and people are also telling us that they're feeling improved stability, personal autonomy, and reduced stigma. People have more money available to them, which is allowing them to better access their basic needs, and are reporting decreased involvement in criminal activity. Now, this evidence base is still very much in development. There's a couple areas where I think it's important to recognize that we don't have a lot of studies yet. However, I know that there's many teams working on studies in these areas. For example, there's been limited studies on diversion, and there's a couple of different teams working on this using different approaches in different provinces. And I think we'll be getting some really strong results on this soon. These studies are also showing some of the barriers to accessing safer supply programs. And I think it's important to also recognize that while safer supply seems to be coming in as one of the strong spectrum of options for addressing the overdose crisis and people who use substances, their needs, there's still some barriers that need attention. Some of these things are barriers to accessing programs like limited clinic hours, the need for frequent visits, pharmacy issues. Some programs have a lack of take-home doses. The main thing that is coming out of many of the program evaluations and research is the low program capacity. Safer Supply is currently being scaled up as small pilot programs with very limited ability to address the strong needs within community, and that's limiting the impacts that it can have because these are small time-limited pilot programs in the currently funded model. There's also restricted program eligibility, also frequently linked to the limited program capacity. Many programs are actually triaging people who are at the highest risk of overdose-related death and seeing the most medical complexity from their substance use. And people who are in these programs are also reporting stigmatizing experiences receiving healthcare outside of safer supply programs. And there's also been issues with a lack of continuity of care when people are going into hospital or into prison. Now, as I mentioned before, the evaluation I'm going to be presenting to you today is a second part. It's a continuation of the first evaluation report that was released in 2021. That evaluation was a mixed methods evaluation where we used both surveys and qualitative interviews with clients of the program as well as with staff members. The goal of this second evaluation report is to do continued monitoring of these major client outcomes. In many ways, the report I'm going to be presenting to you today is a little bit like a pulse check. It's checking in with folks in the program at two different time points, early in 2022 as well as in February of 2023, in order to see how they're doing on some of the major program outcomes, as well as to keep an eye on things like the unregulated drug supply and their use of that. We're also providing recommendations here for the program as well as for the health system, because I think it's important to note here that this is a program evaluation. The main point of this is to actually develop actionable information that the program can then use to roll back into the program operations and provide better services and care for clients. And the first program evaluation that we presented, one of our main findings was actually that people reported very quick decreases in their emergency department use and their use of the number of hospitalizations they were experiencing. And this was questioned because it was from participant self-report data. And I think that it's important to note that, again, this is where we're seeing the coalescing different methodologies looking at some of similar questions. We had a CMAJ publication in September of last year. I actually can't believe that it's a year ago now that this came out, but that also using health administrative data, so data from the health system in Ontario, found the same outcomes. So it also found a significant decrease in emergency department visits, hospitalizations, as well as hospitalizations for serious infections among people after they entered the Safer Supply program, with no change in a matched group of people in the London area who had not had access to the Safer Supply program. And so again, I think that we're starting to see these really interesting data points coming together, which means that we're at an interesting moment in terms of the research and evaluation. So again, today we're going to present the second evaluation comparison of some of the main client outcomes in 2022 and 2023. In order to do this, what we did was we did 75 surveys with clients in 2022. We had a longer data collection window in 2022 from February to April. And then in 2023, we did 95 surveys in February. And as you're thinking about these results, particularly as we get to some of the results around homelessness, I want you to remember that we're collecting this data primarily in winter, at the end of winter, and the impact that that actually has on people and how they're doing. So just to give you a little bit about the numbers, as of the end of March of 2022, there was 237 clients within the Safer Supply program in London. In March 31st, 2023, there was 239 clients. And you'll see very, very strong healthcare interactions with close to 16,000 healthcare interactions, as well as close to just over 2,000 interactions with the social care team, as well as the care facilitators in that 1-year period. So now we're going to move into looking at some of the survey results. So just to give you an idea of the gender of the survey respondents, and as I go through these slides, you'll notice that the data from 2022 is generally going to be on the left side of your screen. Data from 2023 is on the right side of your screen. So in both years, we had approximately equal proportions of women and men, about 55% women and 45% men, who were participating in the surveys, which actually reflects very closely the client balance of the overall program. And also you've got some information there about the racial and ethnic background of survey respondents, with about 72% in both years and around a quarter of people identifying their background as white, and about a quarter of people identifying their background as Indigenous. We actually managed to survey a broad spectrum of people with different time in the program in both years. In 2022, we saw that about 52% of the surveyed clients were actually from 2020 onward, which is the point at which SUAP funding for the program was received, and that the program was able to increase its capacity. In 2023, about 61% of the surveyed clients had entered the program since the SUAP funding was received in 2020. But you're also seeing a significant number of people in both years who've been on the program for a longer period of time, some people up to 6 years in the program. So now we're going to start looking at some of the self-reported data on drug use among Safer Supply participants across the 2 years. For this question, we asked people whether or not they had injected fentanyl from the unregulated street supply in the past 6 months. And you can see that there was an increase from 2020 to 2023 in the number of people reporting even just one injection at any point in the last 6 months. Interestingly, however, in 2023, a lower proportion of people reported that they were injecting every day currently. And so that dropped. And so we're seeing some variability in the way in which people are using fentanyl from the unregulated drug supply. And one of the clear trends in the Safer Supply cohort here, as well as in a lot of the research that's coming out in Canada right now, is this trend towards an increase in fentanyl smoking. We're really seeing that this is a new pattern of use, and I think that this is almost a generational change in the way that people are using opioids from the street supply, with more people reporting currently smoking, both in Safer Supply programs, as well as more broadly among people using unregulated drugs. This seems to, in part, be a sort of overdose prevention measure. People are telling, in some of the qualitative interviewing we're doing, people are telling us about how they feel like they can control their dose more accurately when they're smoking. They can use smaller amounts. As somebody said to me quite recently, once it's in your body, it's in your blood, if you've injected it, then you can't do anything about it. And so I think that this is one of the things that is happening more broadly, and that frankly, our harm reduction programs and a lot of our different reactions to drug use and substance use, we've been a little bit slow to keep up with this. Most of our interventions, our harm reduction interventions, were built around HIV and hepatitis C prevention. So they're strongly focused on injection drug use. And I think that we have to really start thinking about how to best adapt to support people who are smoking fentanyl, because this is a really large change in the way that people are using drugs. When we ask people the changes in their fentanyl use since starting Safer Supply, we see a very, very strong proportion of people who are reporting that they've either decreased or stopped their use of fentanyl completely. There's also a substantial proportion of people in both years reporting that their use of fentanyl stayed the same. And in 2023, interestingly, we're starting to see a small increase in people reporting that their fentanyl use is going up. Again, I think this might have something to do with the homelessness numbers that we're going to be seeing shortly. So just keep that in the back of your mind for when I get there. We also asked people about whether or not they're currently injecting stimulants from the street supply. For most people, this is crystal methamphetamine. Here, there's a lot of stability across the 2 years, where about, a third of people are reporting in both years that they are injecting stimulants from the unregulated supply. And a larger proportion of people reporting that they are currently smoking stimulants from the street supply. I keep on wondering how much of the smoking, both within folks using Safer Supply, but more among people who don't have access to it, is to do with the high proportion of benzodiazepines, unregulated benzodiazepines like atizolam, that we're seeing broadly across Canada being added to the fentanyl, and the strong sedation that those cause to people. And we're also seeing in people, when we ask them their stimulant use and how this has changed over time, about 60% of people saying that their stimulant use has decreased since starting Safer Supply. Again, a good proportion of people, about 20% in both years, 16% in 2022 and 9% in 2023 who stopped. And again, we're starting to see that little bit of increase as well in 2023. Again, I'm wondering how much of that has to do with the benzodiazepines that we're seeing in the street supply. People, when we ask them how they are using their Safer Supply medications, so I'm going to switch a little bit tactics. Now, before we were talking about the use of medications or of drugs from the unregulated street supply. Now we're going to move into looking at some of the Safer Supply medications that people are being given, that they're being prescribed as part of the program. Interestingly, about 50% of people in both years are reporting that they mostly take their Safer Supply medications orally. In 2022, about 40% of people say they're mostly taking their medications by injection. In 2023, this has gone down slightly. And some people saying that they're taking about equal. And so I think that this is a really powerful message, because even though this is a harm reduction program that doesn't actually try to move people towards a cessation of injection unless that's their own personal goal for their use, we do see a strong movement in these cohorts towards a cessation of injection, with a third of people in both of the years here saying that they were not injecting drugs at all. In our first evaluation report in 2021, it was 35% of people who indicated they were not injecting drugs at all. So again, we're seeing this stability in that indicator, in the cessation of injection among clients across all 3 time points. In the survey in 2023, we asked people because we wanted to know how well the medication was meeting their needs, and if there was other medications that they might actually find to be more useful for them. And this is again done in the view of wanting to develop programs to meet the broadest array of people's needs as possible, and to be as responsive as possible to what clients are telling us. And interestingly, about a third of people said that their medication preference, when asking about opioids, would be fentanyl. A third of people said hydromorphone immediate release tablets, which is for the most part Dilaudid. And about 25% of people, a quarter, said that they would prefer heroin. And then you can see the smattering of other opioids that people would like, which is very interesting, because we also have some research coming out of BC on medication preferences. And there it skews much more heavily towards fentanyl. And so this is an interesting difference, and I think really highlights the need for local context to be taken into account when we're thinking about Safer Supply programs and the program development, and really ensuring that we're talking to clients and seeing what their preferences are, because we might be seeing very marked differences across the country in different contexts based on people's drug use patterns, as well as the previous availability of different medications in the unregulated market. In terms of method of administration, about 38% of people said that it would be their preference to have an injectable opioid. About 36% of people said it would be their preference to have a smokable opioid. And around 20% of people said that they prefer to have an oral opioid available to them. And again, here, I think we really do need to pay attention to this strong need for smokable options for people. This has been a real limitation of the Safer Supply programs, the prescribed Safer Supply programs in Canada, in terms of not having available very many smokable, well, in Ontario, any smokable opioid options for people. And so I think that we really need to recognize that this is a strong limitation of the programs as they're currently structured due to the lack of availability of these medications on provincial drug formularies. We also asked people about their stimulant preference if they were to receive a safer stimulant supply medication. Here, 2/3 of people said that methamphetamine or crystal methamphetamine would be their preference. Interestingly, a good third of people actually said that they didn't have a preference for this because they didn't use stimulants. So that's why the N on this one is a little bit lower than some of the others. About 20% of people said that Ritalin would be their preference. And then you can see again a smattering of other preferences that are there for people. So again, just to sum up, I really do want to emphasize that a good proportion of people really would prefer an opioid medication that they can smoke. And as I said before, about 30% of people were very unsure or didn't have a preference because they didn't use stimulants. Now, getting into some of the health outcomes and people's reported health outcomes since they started Safer Supply programs. So here you can see the experience of overdose in the last month. In 2022, there was no people reporting overdose in the past month and 8% reporting overdose in the last 6 months. This has risen slightly in 2023 to 10% of people reporting an overdose in the last month and 15% in the last 6 months. I'll just note as well that this is a place where there's pretty significant variation over the years. In our 2021 evaluation report, 11% of people said that they had overdosed in the past month, so more similar to the 2023 data, and 23% of people reported having an overdose in the past 6 months. 2021 was a particularly bad year for fatal overdoses across the country as well. And so I think that here we do have to recognize the volatility in the unregulated drug supply and how much that is actually what's driving the experience of fatal overdose in terms of the Medicaid or the drugs that people are consuming from street markets. Health systems utilization, we are seeing a remarkable amount of stability here across the 2 years in terms of about a quarter of people reporting that they had visited an emergency department in the last 6 months, and around 13% of people saying that they had been hospitalized for at least one night in the last 6 months. And when we asked people to rate the changes in their physical health, has your physical health since starting Safer Supply improved, stayed the same, or gotten worse? We're seeing about 76% of people in 2022 reporting that their health had improved. And in 2023, this was around 60%. And I'm going to talk about the homelessness numbers in just one second. But again, I think that it's really important to contextualize when people are talking about their health getting worse. There's a very, very substantial experience of homelessness, both current and past homelessness among folks in the London InterCommunity Health Safer Supply program. That's one of the target populations. And I think that we do have to recognize that there's actually limits that, prescription for safer supply and comprehensive medical care can have on improving people's health if you're still stuck sleeping outside on a sidewalk for 2 years or having to go to the bathroom in alleyways. And so I think that we have to also contextualize these findings in that current context. We're also seeing about 70% of people in 2022 reporting improved mental health since starting Safer Supply. About 53% of people were reporting improved mental health since starting Safer Supply in 2023. And an interesting percentage of people, about 33%, reporting that that their mental health has gotten worse since starting Safer Supply. And here we come to the homelessness numbers. And here you'll note that from 2022 to 2023, the number of people reporting having experienced homelessness in the past 6 months went up from 53% to 61%. So the majority of people in both years in the cohort of people receiving Safer Supply in London have a strong experience of homelessness. We actually added a question very quickly to the 2023 survey data collection, because when we were asking people if they'd experienced homelessness in the last 6 months, quite a few people were saying, well, yes, I experienced homelessness in the last 6 months, but I actually just got housing recently. So we added in a question asking if people were currently experiencing homelessness, and you'll see there that it drops. And one of the things that happened in London in over January, the winter period of 2022, late 2022, early 2023, was that several supportive housing programs opened up and started admitting people during that period. And it was quite a few people who were actually telling us this when we were doing the surveys, even though this was just a yes/no question. They would expand on it quite a bit. People were quite happy to have finally received homelessness. And so there is some movement happening in this area. But unfortunately, when we asked people where they were staying when they experienced homelessness, I just want to highlight this for you. In 2022, about 32% of people said that they were couch surfing with family or friends when they had experienced a period of homelessness, compared to 40% of people in 2023 saying that they had been sleeping rough outside in an alcove, parking garage, or doorway. And we are doing this data collection during the worst months of winter. And to see the level of absolute deprivation of homelessness, we know that among folks experiencing homelessness, the trajectory is usually that when they lose a stable place to stay, they will couch surf with family or friends for as long as they can and end up sleeping rough when they've exhausted all other options. And so this movement from 25% of people saying they'd slept rough in 2022 to 40% saying that in 2023, I think is really pointing to the intractability of the affordable housing crisis in London. We're seeing this across the country, unfortunately, not just in London, but this has very, very significant effects on people's health as well that I think can't be ignored. So this is just a recap of some of the stats that I just told you. The one interesting part is that among people in the Safer Supply program, 55% of people in 2022 and 62% of people in 2023 indicated that they were nonetheless receiving support from a specialized housing worker to help them find and access housing, which is nonetheless a positive finding. We also asked people about their contact with law enforcement and their experience of incarceration. Here, we're seeing a fair amount of stability, about 19%, 20% of people in 2022 reporting that they'd had contact with the police in the last 6 months, and about 25% of people reporting that in 2023. About the similar proportions of people reporting in both years that they've been incarcerated at least for one night in the past 6 months. And we also have seen a bit of movement in terms of changes in criminal activity since starting Safer Supply, with in 2022, about 55% of people saying that they've stopped all criminal activity since starting Safer Supply, about 36% of people saying they decreased, whereas in 2023, about 54% of people said that they decreased their criminal activity, with 24% of people stopping. Here you'll notice as well in 2023 that about 9% of people said that their involvement in criminal activity had increased since starting Safer Supply. And again, I don't think that we can disentangle this from the homelessness numbers, and particularly the number of people experiencing very, very strong periods of deprivation. Some of the people who we talked to who had experienced homelessness were saying that they were sleeping on the streets for 2-3 years at that point, and that they were, for example, shoplifting for food because in order to meet their basic needs. But one of the things as well that we asked people was about whether or not they'd taken a break since starting Safer Supply. And here, again, there's quite a bit of stability over the 2 years, with about 16% saying they'd taken a break in the past since first starting Safer Supply in 2022, 20% in 2023, with around 80% in both years not having taken a break since starting Safer Supply. We also asked people for the reasons why they took a break. And And I think that this actually provides some really interesting information for programs in terms of how to support their clients and better support their clients. The major reasons for taking a break were often around having experienced a period of incarceration or having been in the hospital for a long-term period of hospitalization. I'll also note that in both years, challenges getting to appointments was one of the major reasons, with around 20, just under 20%, just over 20% of people reporting that that was one of the reasons why they had to take a break. I'll also note that particularly in 2023, about a third of people who took a break had said that they were discharged or were asked by the program to take a break. And when we asked people what the reasons for taking a break were, people themselves told us that they had taken a break because, or been asked to take a break because they were being disrespectful or aggressive to staff members in the Safer Supply program. And some people also told us that they were asked to take a break because they had been found to be selling their medications. And so they were switched to either all observed doses, or they took a break from the program because of that. Almost all Safer Supply programs that I'm aware of have protocols in place for how to deal with when participants are found to be selling their medications. And here people were very open in telling us that that was the reason that they had to take a break from the program. And it was actually a fairly, I think it was the largest proportion in 2023. So just to sum up very, very quickly, I'm almost at the end. We've almost heard enough of me talking, and then we'll move into the question period. I think one of the main messages for this report is very much that there is quite a strong amount of consistency across the now 3 years of data that we have from program outcomes from London Safer Supply program participants. There is quite a significant amount of stability among clients in the programs across the years. And again, we're seeing this consistency among some of the published research and evaluation reports in terms of some of these very consistent outcomes that people are talking about in terms of strong decreases in their experience in overdose, strong decreases in their use of drugs from the street supply, and improved health outcomes and improved social outcomes. Again, I just want to flag that smoking fentanyl, when we're talking about use of drugs from the unregulated street supply, that was the most common method of use. And again, just flagging that we really haven't been paying attention to this in our program development. It's been difficult to actually build programs within harm reduction. We currently have in Ontario, for example, one supervised inhalation facility that doesn't even receive any funding from the Ontario government because in the consumption and treatment services model for supervised consumption facilities within the province of Ontario, it actually explicitly states that supervised inhalation is not a covered service or a service that the province is prepared to fund. And this is very out of step with what people are telling us about the ways that they're using drugs from the unregulated street supply across several different forms of research now. We're seeing medication preferences. I think this is really important information around the medication preferences in terms of figuring out how to best meet people's needs, with fentanyl and hydromorphone being equally popular among the London clients that we surveyed. And again, we are seeing very, very strong impacts of the affordable housing crisis in this data. This is noted as well in other research. The affordable housing crisis is really reaching catastrophic levels across the entire country right now. And we're seeing this in this data. And clearly we know from existing research on homelessness that people experiencing homelessness, their life expectancy is cut dramatically. And so, I mean, I think that we would be foolish to think that extended periods of homelessness was not going to have impacts on people's health and in their drug use patterns as they attempt to cope with very, very extreme conditions in their lives. In terms of recommendations, I think that one of the things that's interesting about the emerging research right now is we're starting to have some really, really good findings around different program models. I'm always cautioning people when we're talking about safer supply programs in Canada. Safer supply programs look very different depending on your local context and where you're located. Safer supply programs in Ontario look very different than safer supply programs in British Columbia. And one of the things that the London InterCommunity Health Centre, as well as many Ontario programs, is that safer supply as a pilot, as a small pilot program, has been scaled up by community health centres within primary care, where people who start receiving safer supply become become members, they become they have a family doctor who's taking care of their broad health needs. This type of holistic approach, I think, should be seen as a very strong thing. People have many concurrent health and mental health challenges that need addressing. And so models that really take that into account and build primary care services as well as wraparound social care teams around folks are a very, very strong model and very necessary, and provide probably the best value for both participants as well as the healthcare system. I won't say it again. We need more attempts to address smoking of fentanyl and safer smoking services. This is, I think, a very, very important finding that I hope that our policymakers and our governments will begin to act on. In terms of the system level, I think that we see here that there's still continuity of care issues for people who are moving into periods of long-term incarceration or who need long-term medical care within hospitals. And that's one place where I think that across the system, really coming together to work collegially to best meet people's needs is very much a necessity. There's also a need for increased pharmaceutical options. We hear this in the medication preferences that people are talking about, including, again, a very, very strong need for options for smokable medications for people. And again, even though this is a report on safer supply and a prescribed safer supply program, I think that really the strong impacts of the affordable housing crisis come through clearly. And there is a continued need to work on affordable and accessible housing for people who are street involved and who are experiencing the highest levels of deprivation around being deprived of housing. And this should be a key component of our system-wide attempts to improve people's health. So that's what we've got for you. We now are going to have an opportunity for feedback, for questions. I think Rebecca mentioned this earlier on, but it would be great if you could put any questions that you have for either myself or Andrea in the Q&A, and we can start going to some of those now. Thank you very much for coming out and for your attention.
Amazing. Thank you so much, Gillian and Andrea. We're just going to launch a really quick poll. And while we're doing that, please do the poll for us. That would be great. And also, please put if you have any questions for Dr. Kolla or Dr. Sereda, put those in the chat and we'll see. There's a number of them here, so we'll see how many we can address. Let's start through the questions. I see, Andrea, you've been answering some as you go along as well. There's a question here from Sarah. Apologies if I missed this. Is it possible to say roughly how much overlap there is between 2022 and 2023 respondent cohorts?
That's a great question, Sarah. Thank you for asking that. I should have addressed that earlier. We don't know. So in order to ensure that people feel comfortable sharing very, very openly with us, we make it very, very clear when we're doing surveys with program participants that the information that they share with us will be anonymous. So we don't actually take people's names. And we also tell them very, very clearly that the information that they share with us will not be shared with the clinical teams, so that they feel comfortable disclosing things like their use of drugs from the unregulated street supply and their other experiences, for example, their experiences with criminalization. And so we don't actually have a way of knowing how much overlap there is between the two cohorts. This limits us somewhat as well in terms of the fancy statistical methods that we can use to analyze the data. We are actually doing some more extensive statistical analysis of some of this data that we're hoping to publish on soon. But yes, that is definitely a limitation of this.
Thanks, Gillian. Are you able to isolate the Indigenous specific data set to share with Indigenous communities?
That's a great question. I hope that you got my email address. There is actually a possibility that we can do that because even though the data is anonymous, because that's one of our data points, we should actually be able to do that. It would be a small sample size because, as you'll remember, it was about 25% of our cohort in both years. So we'd have to be careful in interpreting the data and drawing conclusions from that. Whenever we move into small sample sizes, we have to be a little bit cautious. around that. But please, I hope you got my email. If not, Rebecca has it. Very interested to chat with you more about that, because that's a great idea and we'd be happy to look into that.
I'd be happy to make a connection there, and also just to all the people attending. If there are questions for Andrea or Gillian after you, please reach out to the community practice. Our emails on our website. Okay, there's the question here about hospital utilization data. So the data indicates some stability. What about information on ambulance paramedic use that refuse hospital use? Do you have any information on that?
Yeah, that's also a really good question. We don't ask that question. And it's a good question because we know that a lot of people, especially people who are experiencing overdose in the community, don't want to be transported and go to hospital after their overdose. And so that's part of the reason why we, that's part of the reason why we ask about their experience of overdose separately from their experience of utilization of the healthcare system. We don't ask about, for example, did you have an overdose that was treated in hospital, which is when we use the health systems data from ICES, for example, that's the data point that we have. And that's actually a strong limitation of the health systems data, is that we can see people who, when we're talking about from the health systems data, the experience of overdose, we're looking only at people who actually went to the hospital. And because that's all we can see. We can't see the number of people who had overdoses in the community or who refused transport to the hospital. And we know, especially since the widespread distribution of naloxone was rolled out in Canada in 2016, 2017, depending on your area, we know that the vast majority of overdoses are treated in the community and don't actually present to hospital. And so we don't currently have access to, like, for this study, we didn't ask people that. And it's also a little bit difficult in the health admin data. There's pros and cons of both data sets, if you will.
Brilliant, thank you. Here's a question. Did participants talk at all about their goals around their use? Interested to see what clients are pointing towards in, oh, where the question just moved, sorry. Towards in terms of pathways within or through Safer Supply, while of course using as maintenance as a legitimate pathway.
Yeah.
Good.
That's a really...
I'll let Gillian go first and then I will chime in.
Yeah. So no, we didn't ask about that. Because this is a survey. And so we were basically just asking people yes, no questions, as well as kind of like the number questions, like how many times did this happen? Check boxes, if you will. But I think that your question points to the value of qualitative research methods, where we do ask people about their experiences and what their needs are, what needs are not being met by programs, how the programs can improve. We're currently doing the next round of data collection here in London, where we're doing one-on-one qualitative interviews with people. We're asking, some of those questions are actually about people's trajectories through treatment, which is a bit of a loaded term, but I use that term because so many clients use that term as well. We're asking them about their experiences with, for example, methadone and other residential treatment programs before coming into Safer Supply, and whether they've been able to access those type of services if they wanted to since being on Safer Supply. And so again, I think that this points to, once again, the value of using multiple different methodologies and multiple different approaches to collect data on programs to inform the widest variety of needs.
And speaking a little bit more clinically to, you know, engaging with people around their goals in their substance use, that is something that we do at every clinical appointment with our patients who are on Safe Supply. It's a key part of our discussions at intake and throughout the time that they're on the program, because we are centering the patient's voice, the person who used drugs' voice, in helping them build towards their own defined goals.
Great.
And I'll just add one more thing. One of the things that's coming out quite clearly in some of the qualitative interviews that we're doing right now, especially since we're asking about this kind of like trajectories question, is that people are reporting, for example, that the care facilitators and program navigators at the Safer Supply program are very helpful when they're looking to find residential treatment or detox options, helping them to get on wait lists. This is something that is, people are talking to us about. They've also talked about how their Safer Supply prescribers are very good about moving them to methadone or Suboxone, buprenorphine options if that's what they want. In fact, we spoke to a couple people who, because they had wanted to move away from using Dilaudid, they had pursued that with their Safer Supply prescriber. So I think, again, we're talking about the multitude of different options available to people and supporting people with wherever they're at in their journeys, and how important that is. I will note that people are continuing to tell us, and this has been a common theme for several years now, about the difficulties accessing residential treatment or detox, incredibly long wait lists, very, very difficult access if you don't have the funding to pay for it. And I think we could all agree that this is something that should be very well funded through the public system, that people have access to the best evidence-based treatment options available to them. And that's not currently the case, and it's a major lack in our system.
Next question. Of the patients who are asked to take a break from the program, how many come back? Do you have an idea of that number?
Ooh, that's a great question. And because we interviewed people who were currently in the program, all of the people who we talked to who'd taken a break had actually come back. And if we're actually looking at the retention numbers over several years, that does seem to overwhelmingly be the case, that the majority of people who do take a break, particularly if they enter prison or go into hospital, do end up coming out. And, sometimes their usage patterns have changed. Sometimes then their, treatment afterwards changes. But that is very much the option, but we don't have an ability to do that in this particular data set because, as I said, we're talking to people who were part of the program at the time of the interview.
Yeah. And again, I can speak operationally. Our team works really hard. If we're aware that somebody is incarcerated, if we're aware they're in hospital, if we're aware of when they're being discharged, we work really hard to bring them back into the program to evaluate their needs, because we know that that is a key risk period for when people may have fatal overdoses in those transitions in care. And then from a programmatic perspective, if we've asked people to step away to take a break because of behavior or diversion of medications, we are always willing to welcome them back into the program with, considerations around how we can make, their participation safer, which can include witness doses at the pharmacy.
That's great. The evidence is very compelling, but opponents to Safer Supply will nitpick some of the details in this evaluation, particularly around things like overdoses, health impacts, etc., and other issues like diversion. Gillian has outlined some explanations around this, but what key messages do Safer Supply programs and advocates need to counter these arguments?
Ooh, so
The big question.
It's a big question. And this is where, I would love to take you through a methodology course right now, because there is a lot of intricacies in the different methods. So I'm going to start by saying that every single one of our published papers on Safer Supply has a limitations section where we try to do our best to actually outline the limitations of both the methodology, the data sources, the sources of bias that might be involved in the study. We take that very, very seriously. And in fact, it's always interesting to me that when people are often critiquing our programs, they're using the limitation sections that I have wrote about our limitations to critique our methodology. And I'm like, yes, no, exactly. That is very much the limitations. That's why I wrote that whole section on the limitations. And so I think it's important to realize that there's no perfect research method. There's different research methods that are stronger at answering certain questions. When we want to get data on how programs are working for people, the best methods are often ones where we actually go in and talk to people directly. And I think here, Andrea's words at the beginning of the presentation around taking seriously the voices of participants in the programs and taking seriously the feedback that they're giving us is very, very important for building strong programs. How else are we actually supposed to build programs that respond to people's needs if we're not actually taking seriously what they're telling us about the strengths and limitations of those programs? Again, here, I will note that we're seeing a coalescing of the data across multiple research methodologies. So the fact that we have qualitative methods, the fact that we have quantitative methods, survey methods, the statistical analyses, and the fact that we're using health administrative data, which is this health systems data where we're looking at people's utilization of the healthcare system. Again, it's all what we want to be looking at is not the results of one particular study, although each particular study adds to our evidence base and is important. I think what's important right now is the look across. And across multiple studies, since we now have, over 20 peer-reviewed papers and evaluations, where are we starting to see these common themes emerging? And that's the work that is really interesting and that we can start to do right now because there has been such a strong amount of publications on safer supply. At this point, if people are saying that there's no evidence on safer supply, that is just patently false. There is clearly now very strong research evidence being published. We can quibble around the methodologies. We can quibble around the methodological choices, and no one study is going to be able to answer every question. Usually with studies, the best designed studies, we're trying to answer a very detailed and defined research question. These evaluations, I quite like them because we get to ask a lot of different questions and present a lot of data. The other thing that I would note is that there's a strong amount of transparency happening here. We're seeing, this is I don't even know how many page report, probably at least 50-page report that we've just published. There's multiple programs that are putting out these, very data-heavy reports, being very transparent about what's going on in their programs. That is a strength. They're being transparent about what's going well and where the challenges are in order to better inform the response to the devastating overdose crisis that we're all facing right now, and we're trying to work together to address. And so I think that really just calling attention to the wealth of evidence from multiple different teams in multiple different provinces, the way in which different methodologies are being used is a strength because we're able to answer a variety of different research questions. And the fact that different methodologies are coming to similar outcomes. And we're seeing, for example, the evaluation data tells us that emergency department visits and hospitalizations are going down. People who use drugs tell us that. And then we also see this in the health services data. So I think, again, those are some of the factors that I think are strengths and positives. In the data, I'll say one more thing. As a data nerd and as somebody who really, likes to think about program development, we're at an interesting point right now because we're starting to get more and more data about the different program models, which is and how they're working in local contexts, which is going to be really valuable as we're trying to figure out locally in different places. What are the elements of a program model that might work well in particular contexts? If you have a lot of people who are smoking fentanyl, for example, how can we best adapt safer supply programs to meet those needs? That's the kind of data that we're going to start seeing come out now because we can look across multiple studies and across multiple models. And that's where we'll really be able to drive some really interesting programmatic changes, I hope, by looking at this data and looking at what it's telling us.
Great answer, Gillian. Thank you. Will future statistical analysis include analysis of the overlap between respondents who experienced homelessness and respondents who reported outcomes such as increased use, stable or increased criminal activity, worsening health, et cetera, et cetera?
Short answer, yes. And again, like here we do have to be a little bit careful about the small n problem. As we start to kind of like break down kind of like the people experiencing homelessness is a fairly large group, so we can actually do quite a bit with that group. But yes, I do think that is an important question, is kind of trying to figure out who are we seeing the best outcomes in, according to what circumstances they're in.
Have there been differences from 2021 to now regarding the potency of the unregulated supply versus prescribable options? If so, how can prescribers keep up to what patients need while balancing safety? Great question.
Well, I can chime in on this one as well. Yes, there is a big change in the potency, but not only the potency, the volatility. And really, when we're thinking about what is the most harmful, leads to the most deaths, it's that shifting composition, the shifting volatility of the composition of the supply. And that has gotten worse every year that I have been doing this, that looks worse. And sorry, Rebecca, you archived the question, so I I need to get the second half of the question back
Oh,
here.
sorry.
It's okay.
Oh my goodness, where is it?
I think it was how we balance prescribed options in this context with
Yes.
patient safety. Yes, and so we know, as you know, the volatility increases, that people's tolerances to fentanyl increases, because we've seen an enormous shift in the amount that people are using. That what we're currently prescribing does not meet the needs for everybody. Hydromorphone no longer meets the needs of everyone on the program the way it could prior to 2020. And so we work really hard to, you know, incorporate multiple options within the Safer Supply program to meet people's tolerances. So not only do we prescribe the short-acting hydromorphone for their Safer Supply, as most people are familiar with, but we add what we call longer-acting backbones. So in addition to people's hydromorphone, I will often prescribe methadone as a long-acting backbone, or Cadian, which is a 24-hour morphine product, to help balance people's tolerances with what we're actually able to provide them with because of our provincial formulary and numerous other factors. But just like I said, we need a spectrum of options in substance use healthcare, whether that's abstinence, methadone, buprenorphine, everything in between, and Safe Supply. Within Safe Supply on that spectrum, we're also working hard to explore and develop alternate molecules. So for some people, for most people, the hydromorphone remains sufficient. But as Gillian alluded to, some people would benefit from prescribed fentanyl. Some people would benefit from prescribed, particularly inhalable heroin. And so those drugs, those molecules are not currently available to us. So significant work is being put into that we can actually offer people what they need within the cohort of Safer Supply patients.
Super, thank you. Adverse outcomes for people in the program. Have you come across adverse outcomes? Can you talk about that?
Yeah, no, so I think that when we ask people about some of the things that are not working well for them on the program, one of the things that we will frequently hear from people is the frequency of visits can be difficult for folks. For most people, especially when they're titrating onto the program and until they have some measure of stability, they're coming into the clinic to meet with the healthcare team on a weekly basis. So that's one of the things that people can often will tell us is difficult. And you saw that in the reasons for taking a break from the program as well. And so I think that there is a question there in terms of how to balance, you know, the need to see people to help stabilize their health issues, to, you know, make sure that they are, you know, getting a good dose of Safer Supply, like all the initiation titration questions, and then with kind of like when's a good point to start decreasing the frequency of visits, so they're being seen, you know, bi-weekly or monthly. Again, this is, I think, a question that once we start to get a little bit more time in the program, a bit more of the health systems data, I think that we'll start to actually be able to answer some of these questions. This is an ongoing question within, for example, OAT treatment as well, with methadone and buprenorphine, is like, you know, how do you find that right balance of visits for folks? So that's one of the things that we hear a lot about from people. We hear a lot in terms of adverse outcomes, in terms of the stigma and discrimination that people face more broadly across society, as well as within the healthcare system. It's unfortunately very, very frequent that when we're asking people about, you know, what's not going well with them for the program or what could be improved, that they tell us that, for example, their pharmacists are, you know, they can clearly see the difference in the way that their pharmacist treats them compared to other clients. That's not to say that all pharmacists, they often also will tell us about great pharmacists and great interactions with their pharmacy care team. We also will hear very frequently from people about quite significant experiences of stigma and discrimination when they're attempting to access broader healthcare services, for example, in the emergency department and in hospitalization. We'll frequently hear from people about having to go through withdrawal when they're in the emergency department or within hospital because their tolerance level and their need for opioids is often questioned quite significantly. And that is not a pleasant experience for people. People really, yes, it's often a very, very difficult and sometimes quite traumatic experience for people. The other thing that we've heard quite a bit about is when people do have periods of incarceration, about that. There is not a single person I have spoken to who has had their safer supply continued during a period of incarceration. And so quite significant experiences of withdrawal when they enter into prison or jail, and then move to other options, for example, methadone or buprenorphine products. Increasingly, we're hearing a lot about people being only offered injectable buprenorphine, even people who are quite stable on methadone or other options, being told that their only option within the prison system is injectable buprenorphine products, what's commonly known as Sublocade. And so again, I think that we have to recognize that there is pros and cons of each different medication and treatment option. And there's likely significant detrimental effects to taking people who are stable on one form of opioid agonist and forcing them to move over to another one. And that seems to be happening increasingly within prison settings, and which is quite concerning, particularly from ethical and human rights standpoints.
And actually, you've just, oh, sorry, Andrea.
No,
Go ahead.
just to add, and Gillian leaned into everything I wanted to say very well. And I think from my perspective, I think it's important that we think about when we're talking about adverse outcomes for people on the program, are the adverse outcomes from the program, from the prescribed safer supply, or the adverse outcomes from the system and ongoing use of the unregulated supply? And Gillian did a good job explaining some of these factors around, stigma going into the emergency room so that you don't stay to be assessed. That, causes significant adverse outcomes in our patients. Not being able to continue their medication in different settings, significant adverse outcomes as well. When we're looking, and this is more from our CMAJ paper, we do know if we're looking at medical effects, we have shown that people have to go to the emergency room 50% less, are admitted 50% less often, and have 50% less invasive infections. So if we're actually looking at adverse outcomes of injection drug use, of fentanyl use, then those have gone down for people on the program. So again, kind of reframing where the harms are actually coming from.
I really appreciate you adding that as well, Andrea. One of the questions that Gillian, you answered, the following question I was going to go to was from someone asking about if people are at higher risk of overdose if they lose access to safer supply, and you explained, you gave a few examples of situations where people might lose access, like when they are incarcerated. There's also an article published today about rates of safer supply prescribing or people on safer supply decreasing in British Columbia. Are we experiencing, because of some of this backlash, are we going to be experiencing some deprescribing? And we know that deprescribing has originally created or contributed greatly to the crisis that we're currently experiencing. So any comments on? And related to that is another question about safer supply programs having difficulty finding MDs or NPs to prescribe. So yeah, do you want to?
Can I just talk about the deprescribing question really quickly, because I think it's a very, very important one. So we're actually working on this right now in a number of different ways, using a number of different data sources. But I think it's really, really important to note that we've known for literally decades now that the most dangerous period for a fatal overdose for people who are opioid dependent is after a period of forced abstinence. So for example, people who get put into prison, who are in hospital, or have other period, or coming out of a treatment facility where they are not receiving an opioid agonist treatment. We know that this is a period right after those periods that their fatal overdose rate goes up dramatically. We've seen this in multiple different settings, in multiple different countries, across multiple different data sets. This is well-established evidence. We also know that one of the things, as you mentioned, that fueled the overdose crisis that we're seeing right now was the rapid deprescribing and forced tapers that happened among people who were stable on high-dose opioids starting in the period around 2010. In fact, there's really strong mathematical models, mainly out of the United States, showing how much this deprescribing and moving people into the unregulated market contributed to the rapid increase in overdose-related deaths that we saw through the starting about 2015 2019 in both Canada and the United States. So I think we have to be very, very careful right now, because if people are stable on a high dose of opioids, whether it's through an opioid agonist treatment, so methadone, buprenorphine, slow release oral morphine, or through a safer supply modality, and they are rapidly tapered or forcibly deprescribed, this is a very high risk period for fatal overdose. All of the existing evidence base that we have will suggest this. This is why every single Canadian opioid agonist treatment guideline recommends against forced tapers or rapid deprescribing. And so I think we have to take this seriously. Calls to deprescribe people from Safer Supply will predictably lead to an increase in fatal overdose deaths based on all of the available evidence that we have again. And we have cohorts right now where we're planning to look at this, because we know that this deprescribing is starting to happen, particularly in British Columbia. And we know that it's going to be dangerous. And as a researcher, it's going to break my heart to watch people die in the cohorts that we have through the health administrative data, because we know that this is going to happen from deprescribing. Every bit of evidence we have says this, and every bit of evidence says that this is a dangerous thing to do.
Thank you, Gillian. Here's a question about scaling up. How would a scale up in the province of Ontario differ from BC? Despite leaning into safer supply, decrim, etc., BC is currently experiencing the worst overdose death toll since 2016. Is this a problem with their model of care for harm reduction in your view? If so, any insights as to how to improve the model would be appreciated.
I think, and I'll start, and I know Gillian will have more to add to this as well. The way that Safer Supply is practiced in BC and in Ontario was quite different. So in BC, Safer Supply emerged as a response to the COVID pandemic for social distancing, keeping people safe from infections, and they called Safer Supply risk mitigation. So providing people with medication so they have less contact with other people in their social networks. In Ontario, Safer Supply is almost always embedded in community health centers or other healthcare agencies that provide robust primary and wraparound care. And so our model is very different. In BC, we're aware that most people receiving a prescribed Safer Supply do not have that primary care. And so it's very complicated whether the difference in the models are actually driving overdose rates, and Gillian can speak more to this than I can. Or again, is it related harms? Are they having more overdose deaths, as all provinces are, because that supply is more volatile, the supply is more toxic? We're seeing, the infiltration of benzodope and trank dope and everything else. That is why overdose rates are increasing in our provinces, not because of the presence of Safe Supply. And certainly we know we could mitigate that with the scale up of prescribed Safe Supply, particularly in the model that we operate in London.
Yeah, this is a really, really good question, because I think that there's been a lot of discussion about scale up of harm reduction approaches, but we haven't actually seen a ton of actual scale up on the ground. Remember, Ontario has been capped at 21 supervised consumption sites since 2018. The majority of communities in the province of Ontario do not have access to supervised injection sites. They do not have access to Safer Supply programs. We don't actually have anywhere close to the need currently for harm reduction or treatment services, quite frankly, evidence-based treatment services that are necessary. We've never, ever seen a scale up of resources in either harm reduction or evidence-based treatment to match the very, very rapid, almost exponential rise in overdose-related deaths that's related to the presence of unregulated fentanyl in the drug supply. And we see this clearly in the coroner's reports on the toxicology, the postmortem toxicology, in terms of what are the drugs that are actually responsible for these opioid-related toxicities. It's overwhelmingly 90% in Ontario, 85% in BC, 95% among youth. It's fentanyl. that is responsible for drug-related deaths from the unregulated street supply. And so I find it like in the London context, for example, there is one supervised injection site and one safer supply program for approximately an estimate of 6,000 people who are injecting drugs. There is nowhere near the coverage of harm reduction interventions necessary. Most safer supply programs are very small pilot programs. This is what they were funded as from the federal government. They're mostly, serving a couple hundred people at a time. And so I think that we have to really, really be careful when we're talking about, this problem of how are we addressing the overdose crisis. We have strong evidence that harm reduction programs work. We have strong evidence that naloxone distribution increases, that increasing overdose prevention site coverage and increasing OAT in BC in particular led to a substantial decrease in overdose-related deaths in 2019. That rapid increase that we saw in that period was responsible for averting a significant number of deaths. So I think that we need to continue. The problem is that it's been very, very difficult. And we've seen increased overdose death rates in cities that have supervised consumption sites and safe supply programs, just like we've seen it in cities that don't have them, and particularly in the rural and remote areas where they often don't have any harm reduction coverage whatsoever. And so it's really a question of scale. We have never scaled up the evidence-based interventions that we know could have an impact to the level that we would expect them to have a population level impact. And that is a problem. It really is. And I don't think we're talking enough about that.
Thanks, Gillian. There's a question here that I think is a really nice one to finish up on. It's asking about, what's happening with homelessness, people sleeping rough, and importantly, what are the outcomes for people who are not on the program versus people on the program? And you have talked a bit about this, but I think it gives you a chance to, again, sort of summarize some of the findings that you're seeing and some of your hopes for moving forward.
Yeah, this is a really, really good question. And again, this is a question that we can't answer with the evaluation data from the London program because we're only talking to people who are receiving safer supply for this program evaluation. What we can do is we can speak to some of the Health and Service Administration data and the CMAJ paper that I mentioned earlier, as well as the Ontario Drug Policy Research Network Rapid Evidence Review can provide some good overviews. But the CMAJ paper, what we did in that paper was we looked at folks getting safer supply in London, and then we actually created a matched group of people also in London who had evidence of an opioid use disorder. So people who were being exposed to the same risk of harm as folks in the Safer Supply program. And what we saw was that while the Safer Supply program participants had a rapid decrease in their health system utilization, their healthcare costs, there was no change among folks who were not receiving Safer Supply. So who were kind of like, treatment business as usual. And so that does provide some strong evidence that these programs are having an impact in the people who are receiving them. Again, it's a question of access. Who's actually getting access to the programs? The people getting access are doing quite a bit better. And the people not getting access and I will admit here, our research is still limited. There's quite a bit of this type of analysis that's going on right now in both Ontario and BC. I know there's quite a few studies underway using health systems data that are going to be able to inform us on this. And so I think that this is going to be a place where we're going to see a lot of evidence published in the next little while. It'll be an interesting moment for kind of like informing some of those questions.
Thanks, Gillian. I'm going to bring us to a close. And to do that, I'd like to share this word cloud of the names and initials of people, of the people who our attendees today put in the chat are the loved ones of the people who've been here today who have passed away who have died due to the crisis that we're experiencing in Canada. Just take a moment to look at all those names and initials. This is why we're doing this work. Thank you so much, Gillian and Andrea. to all of our attendees for taking time out of your day to come and listen and learn. Learn about the program, learn about the evidence, and learn about how we can communicate about Safer Supply and the work that's happening to try to make the world a better place for people who use drugs. We will have the recording of this webinar up on our website as soon as possible, along with, and you can find the report right now on our website. I'm just going to change the slide so that you can see our website address there, and we'll invite you to visit there to get more information. And also, please feel free to reach out to the community practice team. We'd be happy to pass on questions to Dr. Kolla and Dr. Sereda, and make sure that you have access to the report, the recordings, the slides, evidence briefs, anything else that you're looking for. Thanks so much for being here today. And Dr. Sereda and Dr. Kolla, thank you so much for your work here. Again, like you have already mentioned, Gillian, it's great to see the evidence base growing, that we're able to start understanding what's happening and answering some questions, and yeah, learning more.
Thanks for having us.